So yes, very recently published a cohort of patients treated in the UK with a upfront bone marrow transplant for mantle cell lymphoma. This is an allogeneic stem cell transplant. This is from somebody else into them, rather than autologous you back into you, which is kind of standard of care. It's quite an old study now. There was 5-year follow-up, and 80% of patients are alive at 2 years, basically, if you do that. So if you use an allogeneic stem cell transplant early, then it's well tolerated, better tolerated than if you use it later on, and you get some long-term survival. Now, I would not advocate doing that as the standard of care in young patients. However, since that paper was conceived, we now know of a small group of patients who do spectacularly badly with conventional treatment, including BTK inhibitors. It's about 8 to 10% of patients. They have a thing called a p53 mutation. If you've got that at diagnosis and you're young, whatever treatment you use, it's going to work. Well, it's either not going to work or it's going to work for a very, very short period of time, including the new drugs. So for that group, an upfront transplant is the thing to do, and that's what I do now. A number of my peers around the world don't necessarily agree with that, but I think it's the right thing to do. And there's a paper published, actually a companion paper to ours in the British Medical Journal, that shows that in that group of patients, a transplant actually overcomes that bad prognostic feature. So for my young patients, I check p53 mutation status. If they're mutated, then I will do an upfront allograft. It's very few patients, but I think that's the right thing to do. So it's not an evidence-based situation. I mean, it's my opinion, I guess, based on knowing these patients are going to do badly and knowing that a particular approach, you can get over that bad prognostic feature. So colleagues, particularly in France, their belief is you should just give conventional treatment, knowing they're going to relapse, and that's when you do the transplant. So basically, you're reserving it till later on, and there's some good arguments for doing that. The difficulty I have with that approach is that you can take a patient through an autologous stem cell transplant, and a number of them will not be fit enough subsequently to have an allogeneic stem cell transplant. So I think you get pretty much one bite of the cherry there. So I would rather go for the curative approach first, accepting that has a mortality associated with it, whereas an autograft doesn't. So it's a higher risk thing to do, but potentially higher gain. But that's my approach to it. I'm not saying it's right, but that's just why I do what I do. There'll never be a trial to prove it, but I think as we understand prognostic factors better, then we can pick these really bad people. And I think in them we need to do something different. And it may be that combinations of new drugs might be effective there. Venetoclax plus ibrutinib looks good in that group of patients, but I doubt it's curing anybody, so we still have to do something else. So I still think there's a role for a transplant.